Hello, everyone. I'm Dr. Gentili, Chair of the Department of Psychiatry at Wright State University. Welcome and thank you for joining us. I'm the Project Director for Ohio's Coordinating Center of Excellence in Mental Illness, Intellectual Disability, and Ohio's Telepsychiatry Project for ID. I work with the Ohio Department of Mental Health and Addiction Services, and as part of that work, I'm honored to present this training on intellectual disability for DSPs and for therapeutic program workers. So as we go through the presentation, I'll be going through slides which you should have access to. And if you have questions, then please feel free to enter those into the chat box. We will have time at the end to go through a few questions. Okay, so here are our objectives. We want you at the end of this training to be familiar with various behavioral presentations of patients with co-occurring mental illness and intellectual disability. We want you to have a clear understanding of your role on the multidisciplinary team and the uniqueness of your contributions to the team for the individual that you're serving with ID. And we also want to talk today about some various nuances of interviewing techniques and some strategies for de-escalation when persons with ID have behavior change, including agitation, aggression, etc. So, by way of introduction, mental illness and intellectual or developmental disabilities, or ID, are two different conditions. But people with developmental disabilities are more likely to have mental illnesses. They're just more prevalent in this patient population. Mental illnesses can affect memory, perception, judgment, and a person's ability to understand or comprehend what's going on around them. The term dual diagnosis is used for children and adults who have a developmental or intellectual disability along with a co-occurring mental illness. And that's the patient population we're focused on today. So mental illness is treatable. People with ID, however, do not often prefer or may not self-report their own symptoms, as we normally find in the general population. So if you're a direct support professional or a DSP, or if you are a therapeutic program worker or a TPW, you have the opportunity to monitor and document information that can be really helpful to mental health professionals. This is a big responsibility, but you can help identify mental health problems, possible side effects of medications, and substantially improve the lives of the people that you support. Okay, so before we start with the actual content of de-escalation and trauma and interviewing, we want to make sure that we know the purposes of and the job descriptions of the DSPs and the TPWs, because these are the individuals on the team that are incredibly important, and we want to make sure that we're clear about what role they play in the lives of an individual with ID. So DSPs, or direct service professionals, help people live, learn, work, and play in their communities. So in the context of a residential setting, for example, maybe a group home or other supported residential settings, so they support individuals where they live. So the DSP responsibilities may include supporting individuals to live as independently as possible, to help ensure that individuals are healthy and safe at home, maybe supporting individuals in their daily life activities, such as cooking, cleaning, dressing, bathing, etc., and assisting individuals with money management or with transportation to get places they want to go, and potentially finding and accessing community activities. So in employment settings, the DSPs can help individuals find and keep jobs. So a DSP's responsibilities in this context may include assisting individuals in identifying their talents or their interests, goals, and abilities, and supporting them in finding or locating appropriate employment. Potentially also working with local businesses to connect potential employers with potential employees with disabilities. To teach independence skills about how to be safe in their community, for example. As you can see, both DSPs and TPWs are critically important in the lives of persons with ID. There is some crossover in these two roles, but the following information is important for both jobs when you're working with a person with ID and a mental illness. So many DSPs work in communities, and most TPWs work on inpatient units. So that's a big difference. And we're going to address some community information and resources, and then we're also going to talk some about the inpatient setting and what the role of that therapeutic program worker, what they can do to support individuals with ID on the inpatient unit, which can be very different, the acuity of the mental illness, for example. So first, let's talk about communication. People with dual diagnosis may have different communication styles, and we all have to adapt to those, especially when you're having conversations about symptoms of their mental illness or potentially side effects of their medications. So here are some strategies you can use to communicate more effectively and to better support individuals. First, we want to be careful with yes/no questions, with multiple choice questions, or either/or questions. Some people may answer these questions the same way each time. For example, they may say yes to everything or say no to everything, or they may choose the last choice offered because they have memory issues. So if I say either or, for example, an either or question, they may choose the last option because that's the only one that they can remember. And remember, they may be nervous when you're talking to them. They could view you as an authority figure or as someone who has power or control over them, and so they may be very nervous. Consider using some cross-questioning. I like this technique a lot, and it works really well. So this is a strategy that helps you check the accuracy of a question. For example, do you sleep well at night, for example? And then you could also ask afterward, do you have trouble sleeping at night? And this will help the individual, give them another opportunity with the question worded differently. And also it gives you the opportunity to see if the answers are accurate. You want to avoid double-barreled questions, and a double-barreled question is when you're putting two questions combined into one. Sometimes I'll do this accidentally because I'm trying to fill out an intake form, or I have a limited amount of time with an individual during an appointment, for example. So if I say something like, do you like your home and your DSPs who support you, then that's actually two important questions, and I should be asking them separately, even in the event that I have limited time. So we also want to avoid long and multiple questions, such as, do you or do you not like your job? And if so, what is your most or least favorite thing about your job? So that's a lot of questions wrapped up into one, and it's going to be tough for someone with ID to answer all of those effectively. We also want to avoid leading questions, such as, you knew you weren't supposed to do that, didn't you? So that's leading them down a road. That sort of signals to a person how you want them to answer that question, and it also sounds sort of accusatory and disrespectful. So when spending time with a person that you support, we always want to pay close attention to their mood changes, to their attention span, any unusual or repetitive behavior. These are all important to remember or to document so that these can be shared with a healthcare professional. These are a lot of things that we can help people with and support them in different ways, or just give them more information about how to manage those symptoms. This knowledge of their nonverbal communication can really help you and mental health professionals with really valuable information for clinical decision making. Also, there's this important piece of literature out there that helps us to get good information from individuals with ID or with other cognitive deficits. So asking what else can be really, really helpful. And so if you're trying to get the individual to tell you a story or to give you information about a certain point in time in the past, and you're getting partial information, for example, what happened last week at bowling league, then they may give you some information. And if you say, what else? What else? If you say this 2 or 3 times, you're giving the individual more opportunities to provide additional details. And as you're talking about that night at the bowling league or at the bowling alley, they can remember more and more information if they have a little bit more time. So this is actually a scientific fact that was identified in the literature. So asking people what else is actually high yield. Also, using direct open-ended questions, such as when you went to the movie theater and you looked in your wallet, what was missing? So this is important because it's an open-ended question. There's a lot of potential answers to that question, but you're also taking the person to a specific date and time or a specific location, and you're asking them, instead of saying what happened at the movie theater, you're asking what happened at the movie theater when you looked in your wallet and something was missing. So you're taking them to a very detailed time period, and you're more likely to get high yield, accurate answers. So summarizing and recapping what you think the person has communicated to you can be a really useful strategy. So if the patient answers me during an appointment, for example, and I'm not quite sure exactly what they meant, then if I try to summarize it, so is this what you meant? Or if I try to recap for them, if I have a solid therapeutic alliance with my patient, then they're very likely to clarify that for me if I didn't get it quite right. And then I can take responsibility for, oh, I'm sorry, I didn't realize that that was what you were referring to. But it's also a sign that I'm interested in what you have to say, and I want to make sure that I understand you correctly. And so can I just recap that for us? I also do this in appointments if I'm talking to the patient one-on-one, and maybe there's a caregiver or DSP, or maybe there's a family member that's outside, and I'm going to link them in. I'll ask the patient's permission before I do so. So in other words, I might ask, okay, we talked about a lot of different things during our time one-on-one. And so before we bring your mom back in, I want to make sure that we're clear on what we're going to share with her. So there may be some sensitive information that is not a safety issue, but something that the patient wanted to talk one-on-one about. And so I want to clarify with them and get their permission to be respectful and to remember that it's their appointment before a third party joins. And so we can have sort of a game plan and agree on that. And remember, these are just suggestions. You know how to best support the people that you're linked with and who are on your caseload or who are on the hospital unit. And so it's not necessary to use every strategy, and not every strategy will work with every person, but these are just some suggestions. So let's talk a little about baseline functioning. This is really important because mental health professionals may ask DSPs or TPWs to help document someone's baseline functioning. So in other words, what does it look like when this person is doing well, when this person is healthy, and when their mental health symptoms are either resolved or they're well controlled? Where are they living? Who are the individuals that they're interfacing with? Are they working? Are they in school? Are they in some kind of habilitation or programming during the day? Who are their important people in their lives? And so all of these details are important to document. And often I get these details about my patients from the TPWs and from the DSPs that I work with on the team. It's incredibly important to have these details and to be able to share this so that we can help the person regain stability or to get back to that highest level of baseline functioning. Mental health professionals can establish a normal or baseline functioning for each person that we support. And you can do the same thing in your job so that we sort of know what we're shooting for, what our goal is in getting this person back to their best level of functioning. So some requests for information or documentation from you during an appointment, for example, with a healthcare provider, a counselor, a social worker, a case manager, could be describing what type of communication style the person prefers when interacting with healthcare professionals or other people in the community. Also, identifying details of when the person was last doing well, such as what medications the person was taking, what were the environmental factors, the housing situation, the support system, and quality of life factors. Those are all really important for us to be familiar with and to know. Okay, so transition age is a really important time. We will sort of roughly define transition age as 16 to 26 years of age. So give or take, some people will start transition age a little earlier. Maybe there are puberty changes that happened earlier, and that starts some hormonal changes, for example. Sometimes it's when this time in life where there are self-identity questions. Who am I? What is my role? Who are my friends? What are my goals for the future? It could be changing from an educational setting, from school to a work or programming setting, for example. It could be the first time, and it often is the first time, that a mental illness will present itself. And it could be a common time for an existing mental health issue to worsen, for a person to decompensate, because all of these changes can be very, very stressful. It's also a common time for individuals to change from living with a family, for example, their family of origin, to another supported residential setting, for example. So while people are making all of these transitions, there's all different kinds of changes going on. Puberty, we mentioned, these are these significant hormonal changes that people go through. And this also causes changes in relationships, for example. Puberty tends to be difficult for everyone, and certainly including people with developmental or intellectual disabilities. It's also that common time for potentially the hormones to be affecting anxiety levels or depression levels, for example. So it's a time when people really need that multidisciplinary team on the mental health side, as well as their team on the DD side. And whether they're in the community, whether they're in the hospital, and that's why this training is specifically for DSPs and TPWs. Let's talk a little about suicide prevention. So suicide, certainly, the suicidal feelings and gestures can certainly occur in the ID patient population. A person with developmental disabilities may have other factors that make them more likely to complete suicide or to consider it, including their disability status, a mental health diagnosis, for example, a history of trauma, which is incredibly common in this patient population, recent stressful events, chronic pain or other medical conditions, or just impulsivity and agitation, which many of our patients struggle with from time to time. Anyone who shows signs that they are thinking about suicide should be taken seriously, and DSPs should follow the appropriate steps outlined in the person's mental health treatment plan or in their individual service plan or their ISP. DSPs can also call 911, or we now have that new number, 988, and this is a national crisis or suicide prevention hotline. So 911 is for medical emergencies, and 988, which just came live in the last couple months, this is for mental health emergencies. So these behaviors may be signs that someone's thinking about suicide. These include potentially talking about feeling empty or hopeless or having no reason to live, making a plan or looking for a way to kill themselves, such as searching for a lethal method online, stockpiling pills, or purchasing a weapon. Talking about feeling trapped or feeling that there are just no solutions to their problems, using alcohol or drugs more often. Also, another signal or a flag is withdrawing from family and friends, changing eating and sleeping habits, showing rage or talking about seeking revenge on someone, or talking or thinking about death often. And so again, make sure that we're all aware of 911 and 988. Those are both such important resources. Next, we want to talk a little about anxiety disorders. Anxiety disorders are actually the most common mental disorders in the United States for all patient populations. Anxiety is treatable, and if it is suspected, the person should be evaluated by a family practice physician or a psychiatrist, depending on the severity. And we're going to talk a little now about how you would determine how severe the anxiety is and who to call or how to link the person with services. So to determine if a person should consider seeking treatment for the anxiety, ask some questions like, does it disrupt their daily schedule or their daily plans? Is it causing the person to be late? Is it interfering with relationships? Are their symptoms taking up more than 1 hour daily? For example, if they have to have rituals, if they're repeating things, if they're flipping light switches on and off, if they're in a restroom for an extended period of time. Are the symptoms causing other mental health symptoms? For example, if someone has anxiety and it's untreated and it goes on and on, then oftentimes the person will start to have depression, and you'll start to see not just the symptoms of anxiety, but you'll also see co-occurring depression with that. They often run together. Is the person struggling? Is it just a struggle for them? And we can help identify that and get them the care that they need. Another thing in the ID patient population is perseveration, and this is when someone is repeating comments or questions over and over and over. This can be related to obsessive compulsive disorder. It can be related to generalized anxiety or panic disorder. So there's all different types of anxiety disorders. And if someone appears to be struggling with anxiety, then we want to take note of that, and we want to document it and consider linking them to services. Perseveration, or that repeating questions over and over or repeating comments, the person is looking for affirmation. They're looking for an answer or a response that will lower their anxiety. But the anxiety is causing them to ask that or make the same comments over and over. So it's usually related to anxiety, and it can be addressed by a mental health professional who can provide guidelines and boundaries to reassure the person. For example, if someone is asking a question over and over, we could make a plan together during the appointment. For example, the first 2 times that you ask that question, I'll answer the question, and then after that, I'm going to help you remember what the answer is. So you're sort of working with the person so that they can help themselves, as opposed to needing a second person to constantly reaffirm or quell their anxiety. So with the support of the person's team, the DSP or the TPW should reward or acknowledge when the person follows the guidelines or boundaries outlined by the mental health professional. This is something that maybe a social worker can help with too, or a therapist, a counselor. So when this happens, you could do some slow, deep breaths. When you have that same question, we could write that down on a piece of paper so the person has a visual. So there's lots of ways to address this, but the person asking that question over and over can become difficult or frustrating for people around them, but they're literally just looking for affirmation or reassurance, or for someone to help them decrease their anxiety. And again, a lot of these anxiety disorders, there are medications that can help patients with that, so that it's not just up to them alone. It's that they don't feel alone in trying to decrease that anxiety. So now we're going to talk a little about post-traumatic stress disorder, or PTSD. So this can occur when a person has experienced trauma. It doesn't happen to everyone that experiences trauma, however. Trauma is common with people who have experienced sexual, physical, or emotional abuse. Exposure to life-threatening events typically invokes this fear or panic response, and maybe a feeling of helplessness and panic. People can exhibit re-experiencing when you're thinking of the trauma over and over and over, and you can't seem to move away from it, or avoidance. This is when you sort of close yourself off and you avoid certain activities or certain geographic locations or talking to certain people. And then arousal. And this is when you have this increased emotional or motor activity in response to the situation or the environment. So a DSP or a TPW identifying and recognizing the signs of PTSD can be the first step in getting the person to the right supports and the right treatment. We're going to go through these 3 categories that I just listed for you in a little bit more detail. So this hyperarousal state, maybe you have seen an individual who is struggling with this hyperarousal state. They have this fight or flight response. They're sort of on alert, so they can overreact to things. So maybe it's a small change in schedule, but they're completely overreacting to it, as if this is this huge pivot that they have to make. It can be this random physiologic response, so they could have this rapid heartbeat. They can have these short, quick breaths instead of normal breathing. So they're actually changing their acid-base balance by doing those short, quick breaths or sort of hyperventilating. It can be explosive aggression. They can be really irritable or have this low frustration tolerance. And I usually ask people, do you feel the need to defend yourself? That means that someone is walking through life and they don't feel safe. So that's important to identify and to act upon and acknowledge. The second category was that intrusion or re-experiencing. So these are people who have experienced trauma, who they can't move away from it. And so it's in their thoughts, it's in their dreams, it's part of their behavior. And so you'll notice behavior change with individuals in this category. So it's almost like they are still in that moment of trauma, like time has stopped at the moment of trauma. So post-traumatic behavior can be obsessive. So they can be repeating things, they can obsess about something, they just can't get those thoughts out of their head, or it can be literal. They can take things in a concrete way, and they may draw pictures, or they may behave in certain ways that are literally sort of copying that moment of trauma, sort of reenacting the trauma. And so if you have flashbacks, that means you're having that intrusion or the re-experiencing while you're awake. And if you're having nightmares, that's having the intrusion or re-experiencing while you're sleeping. So those are two different things, but all connected to that intrusion. So this is the constriction and avoidance, and this is sort of a state of surrender. This is a person who sort of shuts down. So, okay, that relationship ended, and so I will never again have another relationship. You're sort of circling the wagons. You're sort of escaping from life itself, not by action, but by sort of turning yourself off or numbing yourself to your environment and those around you. So oftentimes, because people are shutting down and they're changing their state of consciousness, they often won't be able to remember important aspects of the trauma and won't be able to recall or share those with you. And they also can have changes in pain perception. So sometimes they'll experience something where they should be or normally would be feeling pain, but they're not doing so because they're numbing themselves to things. So trauma in general, we want to make sure that when you're communicating with individuals with disabilities, if their communication is impaired somehow, their hearing, their memory, their speech, we want to make sure and speak simply and slowly. That can be really helpful for people. Take the word of the person who claims to have a disability, even if it's not obvious to you or it's not familiar to you, when you're unsure of how to help. I find it's helpful just to say, what can I do for you right now? How can I help? And trust what the person tells you. When possible, we want to enable and empower the person to be self-sufficient. So if there are things that they can do for themselves or decisions that they can make by themselves that are safe, then it's important for us to allow them to do that. Some things to avoid when someone has just experienced trauma. We don't want to assume that everyone exposed to trauma will be traumatized. In other words, some people will receive information or will have a perception or will have internal or external resources that will allow them not to experience trauma, and that's okay. We also don't want to treat people as if they're broken or there's something different about them. Most acute or upfront reactions or immediate reactions to trauma are understandable and expected, given whatever the individual was exposed to or may have experienced. We want to talk in a respectful way and focus on, we do not want to focus on them being helpless or weak or on their disability. We want to focus instead on what a person has done that's effective or something that may have contributed to helping others in need. I've had lots of patients during traumas who help others, who try to protect and advocate for others, and focusing on that and pointing it out and acknowledging that can be really empowering for the individual. We also don't want to assume that all survivors of a trauma want to talk about it or need to talk about it. One thing that's important after a trauma is that we allow people to talk about it in their own time, in their own way, and that they need to be in control of that. And it might not be right away, it might be down the road. often being physically present and supportive and calm affects people and makes them feel safe and more able to cope. And when needed, just try to assist in an area where there's less noise and less stimulation. And we also want to try to address the person directly rather than addressing a caretaker exclusively or a family member, for example, unless direct communication is difficult or it's adding to the stress of the patient. So when we're working with trauma survivors with disabilities, if community, go back. I'm going to start with this slide now. So what we want to do is we want to divide trauma into stages. And so this has been really helpful for me. This is a theory it's pretty dated. It's back from many decades ago, but it helps me understand where the individual is and how they're interpreting the trauma as it's experienced. And so it's important to understand trauma at each developmental stage. So if someone has mild ID, that's going to look different how they perceive trauma versus someone who has moderate ID or someone who has severe ID, for example. So these next several slides, this is looking at trauma in stages and trying to experience what the individual is at their developmental stage. Okay, so first, this is at the top of each slide. So we have severe and moderate, and this is approximately ages 2 to 6, and this is a developmental stage where most individuals will live, how they will perceive trauma. So the sights, the sounds, the smells of the environment, that can take them back to a point of trauma, certain lighting, a scent of some kind, it can take them back. They may experience and share their trauma with us through storytelling, through drawing, through role playing, through play therapy. So there's going to be different ways that the person can tell his or her story, but it's important to allow everyone that opportunity to tell their story, and that's how we recover from trauma. Someone in the severe or low functioning moderate range, they may regress. They may be thumb sucking. They may sit in the fetal position. They may bedwet, for example. And so this could be an upfront or immediate response to stress. It could be that this is these initial stages that we need to sort of let them go through and try to support them, but we don't want these to be long-term. We want them to go back to their normal way of functioning and their normal coping skills and strategies. It could be that they need repetition. If they're in moderate and severe categories or profound, then they could experience a trauma or a loss of some kind. And I had a couple patients one time, every single time that I saw them for appointments, they would say, "Where's Russell? Where's Russell?" And this was a brother that they lost decades ago. But at the severe ID range, the person doesn't fully understand that these changes, or the death of a brother, for example, that this was irreversible. And so we needed to talk about it every time. And we talked about it for a minute or two each appointment at the beginning. We just sort of went through how Russell died and that they miss Russell and he's in their heart, and some special memories they had of Russell. But it was a repetitive question. And this is one way that someone with severe ID will process trauma. And individuals in the moderate or severe range will often show us that they're upset. In other words, they will have behavior change rather than telling us with words. So we want to make sure and be clear about, we need to watch their behavior and interpret their behavior and tie it back to something important. Okay, so this is mild and moderate. So this is going to look a little bit different. So when you're interfacing with someone with mild ID or with high functioning moderate ID, you'll often you want to think about filling in the blanks. So they may be filling in the blanks on their own if we don't give them information. Often I'll talk to family members or staff and they'll say, "Well, I didn't want to expose them to that. I didn't want to tell them about that because I thought that would be upsetting. But if they don't have the information, that can be upsetting too. So filling in the blanks is the patient not having information and saying, oh, that staff left because of me, when in fact a staff person, there's lots of turnover and there could be a change in location of work or scheduling and that kind of thing, and it could have had nothing at all to do with the patient, but they may try to own that or blame themselves for it. Okay, so this is mild ID, and just a few examples of the trauma experience would be someone who feels really self-conscious about maybe they feel like they look different, or they feel like they're marginalized, or they aren't included in activity. And so these are things that we want to talk openly with the patient about. What's that like? And that sounds like it's really frustrating, and how can I support you? And how can we find people that you want to spend time with, that also want to spend time with you? And they may be concerned about just the immediate future, and we also want to be talking to them about what's down the road for them. So now we're going to pivot a little bit and talk about trauma interventions and how we can talk to people and what we can do to support them after a trauma. So this is moderate ID, and remember that primary caregivers, the people that they feel the most comfortable with and that they know the best, will be the primary source of comfort for the individuals. And you could certainly be on that list, and maybe at the top of that list because of the amount of time that you spend with that individual. And I always like to tell the story about the Norwegian shipwreck, because it's an important lesson in trauma and what we should do afterward. So the shipwreck was a large group of men, and there were brothers, and there were father and son, and there were cousins and really close friends, and there was a storm and the ship wrecked, and about half of the men survived and about half did not. They perished in the shipwreck. And so the survivors were all gathered by a psychologist right afterward, and the psychologist basically had three messages. And the first message was, after you struggle with a trauma such as the shipwreck and losing people important to you, it's normal to have some symptoms. It's normal to have some anxiety. It's normal to have some trouble sleeping. It's normal to feel depressed temporarily. And that's part of the process, the trauma process. But the message number two was, do not turn to alcohol or other substances. So don't make that your coping mechanism or your strategy to feel better or to escape from your emotions. And then the third message was, silence is the enemy. So whether you talk about it right away or you talk about it down the road, not talking about it will only impede your progress. You can't recover from trauma until you have shared it with someone else, and it has to be another human being. It doesn't necessarily have to be a psychiatrist or a counselor. A lot of times it is, and that can be really helpful, and that's proven in science. But if you share it with someone that you trust, that's a part of the process. I like to talk about the safe zone because this is an important concept when you think about maybe an individual who has medical conditions, which is really common in our patient population. If they're going to a hospital or a clinic and they have to have blood drawn, or they have to have a procedure, for example, we want to have a safe zone so that person can know that while I'm in this office area or when I'm in the vehicle, it's a safe zone and there's not going to be needles and there's not going to be procedures. And so we want to tell them what the safe zone is so that they can calm themselves down and know that I do not have to fear or panic or be anxious in this zone, because that can be really helpful. We want to make sure we remember that emotions are not problems. Emotions are signals, and they're signals that are telling us something. So when something bad's happen, it's important to try to find some silver lining, like that bad thing happened and I'm really sorry about that. What I've noticed also is that you've had people that truly care about you, that have stepped up and are spending time with you and reaching out and calling you and making sure you're okay, or that sent you a card, that kind of thing. And also we want to make sure that we're open to the expression of strong emotions, because when people have trauma, they are going to have strong emotions. That's to be expected. But we can help them facilitate expressing those strong emotions in a healthy, therapeutic way, as opposed to with aggression, for example. So we can give them other options. And if they want to sit out some things, sometimes it's good for people to just get out there and be around people and occupy their minds after a trauma. And other people need to just have some quiet time and have to have some options about, hey, I don't want to go to bowling tonight, or I don't want to go to soccer practice tomorrow. I want to take a couple days off and just relax. And we have to let the individual tell us what they need sometimes. So there are stages of recovery, and we know this. This is based in science. We have literature to support it. So the stages of recovery are listed here: establishing safety, reconstructing the story is telling the story in some way, shape, or form, and then restoring your connection to the community. So we know these pathways are evidence-based, and we also know people get better if we guide them through these pathways, and they'll be stronger for it. We want to differentiate grief and depression. These are two different things. So they're not the same. The first stages of grief after an event, such as losing a loved one, usually last less than 2 months, at least the initial stages. And suicidal thoughts are usually not present in normal grief. The person may have feelings of loss, they may cry, but they usually return to baseline. And then in depression, the time course is greater than 2 months. Suicidal ideation is more likely to be present. And we want to identify that, and as we talked about earlier. And the emotional state of the person can include worthlessness and blaming themselves. And psychotic symptoms, if they're present, are usually longer lasting versus grief. So these are two different things, and they should be identified and treated differently. Psychosis, we should just mention because it's important. It can include delusions, which are false beliefs, like the FBI is tracking me, or I have a chip in my wrist and people are following me or making fun of me. They can be paranoid, they can be grandiose, they can be religious or disorganized. So you don't want to confront people. We don't want to argue with them. We don't want to agree with them either. So the best thing to do in these, instead of saying you're not hearing voices, there are no voices, or no one's following you, this is true for them. This is their true experience. So we want to focus on the person's emotions. So instead of saying that's not really happening, we could say something like, that sounds really scary. How can I help you feel safe right now? So that's the best thing that we can do for people with psychotic features or with psychosis. So we want to talk just for a minute about meds. Polypharmacy is when people are taking too many medications. And so if you have a patient and you have concerns about this, it's important to talk to the healthcare provider. And to make sure that people are on the fewest amount of medications and the lowest effective dosages. Otherwise, it's probably just going to make them tired, and it's going to probably worsen memory problems, for example. There's this psychological first aid training, which is amazing. And as a DSP or a TPW, supporting the person to live as healthy as possible, both physically and mentally, is a vital part of your job. So just like there's first aid for physical health problems, these are psychological first aid. These are things that you can do in your supporting role to provide psychological first aid, to model healthy responses, and to be calm, courteous, organized, and helpful, being visible and available to people, maintaining confidentiality as appropriate, being knowledgeable and sensitive to issues of culture and diversity, asking simple and respectful questions to determine how you can help. These things go a long way. They may just sound like common sense to a lot of us, but people notice, and it has a big impact. So really helpful when you're spending as much time as you do with individuals. Remember that all behavior is a form of communication. So aggression and other behavior change are common occurrences at times in people with ID, and they may look like self-injurious behavior or verbal aggression or property destruction. So mental health professionals should consider underlying health conditions that can be causing the aggression. They can also be underlying psychiatric conditions, and with the important information that you bring to appointments and share with healthcare providers, that can help us get from point A to point B in helping people. I am going to go through the rest of these pretty quickly because they're pretty self-explanatory. But if someone is presenting with a certain behavior like rocking, for example, we don't want to just say, oh, that's normal for the person because they have ID. We want to look for medical conditions like abdominal pain, which is visceral pain, headache syndromes, depression and anxiety. That's really common when someone is rocking, and it could also be medication side effects. So it could just be a behavior that the person has created to calm themselves. And if you know the patient well, then that may be the case. But we don't want to miss other things like medical conditions. If someone's biting their hand or their fist, we want to think about reflux disease. That's the #1 cause of biting a hand or a fist. They're communicating to us that they have abdominal pain or they have that burning sensation in their esophagus. And it's really painful, and it's very treatable as well. They can have sinus infections, or they can have asthma, they can have ear infections, or they can have wisdom teeth coming in, which is really painful. But if you apply pressure to pain, that can be really helpful. So these are things that we want to rule out or think about and should be reported to healthcare. If someone won't sit down, it could be a medication side effect. Again, it could be anxiety, depression. We tend to miss anxiety, depression a lot. They could be having rectal pain or genital pain, or it could be a sign that they have abuse in their history, or they're part of ongoing abuse. So something that really needs to be addressed or reported to someone. If they're whipping their head forward, it's important for us to know that individuals with Down syndrome have some joint issues and changes that can cause pain in the lower neck area. They could be whipping their head forward because it's comforting, or it decreases their pain temporarily. Head banging, same thing. This is not normal for anyone. Depression, trauma, dental problems. So dental screenings are really important, and x-rays. Also sinus problems, ear infections, seizure disorders. So there's lots of things that the family practice doctor or the psychiatrist can help with in ruling out. When should we be concerned? When a person experiences a big life stressor, when there's been a death of a loved one or a move to a new environment. So these things can trigger the onset of mental health symptoms like sadness and crying, trouble sleeping, worrying a lot, skin picking, anger or aggression. When a person makes actual threats or attempts to harm themselves or others, obviously that's an issue for concern. If they're unable to care for their basic needs, keeping in mind what their baseline is, what they're normally capable of doing on their own. When they have lost touch with reality, for example, we talked about hearing voices, seeing things, being paranoid, feeling that people are following them or watching them. If they can't make simple decisions for their own safety, this could be refusing to eat. It could be hearing voices. When a person receives psychiatric services through a mental health program and there are questions or concerns regarding medications or possible side effects, that's a time when you want to definitely reach out to healthcare professionals. And if you notice any of these signs or expressions, contacting the mental health professional in place or requesting a referral if they're not already linked. And I'm going to have an email address for you and some contact information if you have an individual who does need services. So what works? Putting yourself in the other person's place and thinking about what control other people have over their lives, including where they live, what they eat, and the clothes that they wear, among a lot of other things. And also, people with ID are often not given choices regarding caffeine or coffee or soda or cigarettes, for example. And while we want people to make healthy choices and we care about their well-being, we also have to keep in mind that we have to balance that with all of these mandates that are often put upon people. Okay, so these are just some practical suggestions as we're wrapping up here. So we don't want to underestimate effective planning. If we plan for patients escalating and for what we will do as a team and how we'll respond, we want to avoid overcrowding situations, for example, try to reduce loud noises, intimidating direct eye contact may not be a good idea. Unnecessary invasion of personal space also will cause someone to escalate. We want to use that soothing tone of voice that can be really helpful. and ask people, what can I do to help you? We can express concern. I care about your well-being. I care about your future. We can offer food and drink. Allowing a phone call to a trusted support person can be really impactful for someone who's struggling. Try to decrease wait times. That's important too. And trying to redirect a person to more positive activities and removing potentially dangerous items from an area. So practicing de-escalation strategies and working as a team, and then talking about it after the fact. Talking about it as a team is important. You can sort of determine what went well and what are our opportunities for improvement next time. And then on inpatient units, I wanted to just share some communication issues. So patients with ID on an inpatient unit may not know where they are. We can help them by just giving them information. This is a hospital. You're here for a short time. Why am I here? We want to take a look at your medications. We want to help you feel more calm. We want to treat your anxiety. How will I get the things I need? That may be a major concern for a patient with ID who's been hospitalized, whether it's in the community or whether it's at a regional psychiatric or a state hospital. There are staff here and they will help you get the things that you need. When will I be able to go back home? That's going to be up to the doctor, but you'll be able to be home soon. We will probably change a couple of your medications. We'll tell you what those changes are. You will still have your job when you go back to the community. Who should I ask for help? Just another common question a person with ID might have. Patients with ID on inpatient units will often be vulnerable to other patients, and this is a serious concern. Other patients may target them for their commissary money, for their cigarettes, for food, for example. They may have a lot of trouble feeling safe. 90 to 95% of them have trauma histories. We have to keep that in mind. They may feel very insecure, have a lack of confidence. So it's important to tell them who will help keep them safe. Who should I go to? If I have questions, who should I ask my questions of? And using concrete, simple language is really important. If the patient's talking in 4 or 5 word phrases, it's important for us to do the same back to them. So try to mimic or mirror their ability to communicate with words. It's important for us to try to avoid slang or random phrases. Often they have fear of needles and of shots, and so giving them some extra attention and support during those times, if those are necessary, is also impactful. Knowledge is power, remember, so if something's going on, if something's going to happen, it will help ease their mind or help them avoid filling in the blanks themselves. That can be a huge benefit if you're the TPW on that unit. Also involving guardians in decision making, if there is a guardian, and then also sharing the information with the individual themselves in language that he or she can understand. Plan to take more time for conversations. It will probably take longer to explain a situation or to provide information to the individual. And if they have limited speech, they'll often behave. There'll be behavior change, and they'll be using that behavior to communicate with others. It could be agitation and aggression. So we want to give them other skills, and we want to find a way to help them use their words or to draw pictures, to use visuals, for example, and then some of those interviewing techniques we talked about earlier. So in summary, ID does not protect one from mental illness. In fact, they have more prevalent mental illness in this patient population. They're more vulnerable to side effects of medications. And we tend to overdiagnose psychosis, and we tend to underdiagnose anxiety and depression. Every person in every agency should be trauma informed, and we just went through a lot of trauma information, and hopefully that'll be helpful. And it's a myth that patients with ID can't benefit from mental health services. And that includes psychotherapies and trauma-informed approaches and behavioral therapy, as well as state-of-the-art medication regimens. I want to thank the 2 state departments, the Ohio Department of Developmental Disabilities and the Ohio Department of Mental Health and Addiction Services for supporting this training. I also want to thank Director Kim Hauk and Ms. Tina Evans from DODD, and Director Lori Chris and Dr. Vicki Montesano from OMAS. If you have questions, I welcome them. And these are two pieces of contact information, Ebony and Kelsey. They take referrals if someone is looking for outpatient mental health treatment services or other connections. Please feel free to reach out to us and we would welcome that. This concludes the training for DSPs and TPWs. I'm Dr. Gentili. Thank you so much for joining me and for all the important work you do in assisting our individuals with ID. I would welcome your questions and comments at this time. Thanks for joining us.
All right, Dr. Gentili, we do have one question already waiting for us. Kimberly was asking, as well as OCD, this came through about the time we were discussing the high prevalence of anxiety in the general culture, in the general population, as well as asking questions repetitively and how it interferes with their everyday life.
Right. So sorry, I missed part of that. Megan, can you repeat the question?
Sure. So the question was briefly, as well as OCD, sort of referring to anxiety and the challenges with that.
Right, so OCD actually sits under the umbrella of anxiety disorders in the Diagnostic and Statistical Manual. So OCD looks a little different because you have the obsessive thought processes and then the compulsive behaviors. If the patient is untreated and has OCD, then they'll have those obsessive thought processes. They'll be obsessing about something over and over and over. Did I turn the light switch off? Did I rinse my hands? Whatever it is. Or asking questions if it's verbal OCD. So it can be physical, it can be verbal, behavioral. And if it's untreated, the patient is left to their own devices to rid themselves of or decrease the anxiety of the obsessive thoughts. So they have really limited options. They might, like we've talked about, ask someone something over and over and over. They may make comments over and over, or they may act out the compulsions over and over. If they're treated by a psychiatrist, then they can have medications on board that will potentially increase their serotonin level or decrease their dopamine level that can help them manage those symptoms on their own. If they're untreated, then they're literally just struggling with that severe, significant anxiety, and it's likely going to affect just about everything they do. And so that's why acknowledging that and identifying that and documenting it and sharing it with someone, really, it gets them to that point of being in active treatment. And we can also do the behavioral or the environmental interventions. I mentioned maybe letting them ask a question 2 times and then answering them and then giving them their own devices, another way to answer their own question. So there's so many things we can do. There are so many people with anxiety disorders that are not in treatment. They're literally just left on to their own devices to treat the anxiety on their own, or to exhibit agitation and frustration and aggression, unfortunately.
All right, our next question comes from Carly, who says, would you also consider hair plucking as a red flag for concern?
Yes, absolutely. That's a great question. So depending on if it's eyebrows or hair or hair, whether it's on the face or other parts of the body, it may be trichotillomania, which is a separate diagnosis. And this is sort of paired with some other anxiety-driven behaviors like skin picking, for example. So whether it's hair plucking, whether it's skin picking, we don't have amazing treatments for this set of disorders, unfortunately, but it's compulsive, it lowers anxiety. We have to replace these behaviors with something else that's healthy and that makes sense, for example. So we want to, instead of just trying to take away the behavior or have the patient stop it, first of all, we want to change the environment so they respond to the environment differently. And then we also want to give them another option. So we want to have a healthy replacement behavior that we can give to someone. But we can also be treating these with the serotonin medicines, with the norepinephrine, the antidepressants, the anxiety medicines, and also with mood stabilizers, because those can just treat anything that's impulsive, anything that's repetitive or ritualistic. But we also want to understand that something is happening to make this person anxious, or it's coming, the anxiety is internal. Whatever the case is, this is a form of, or a behavioral presentation that indicates anxiety, and we need to address it and treat it.
Okay, our next question comes from Nikki Parson. Is it possible that a person can have autism that is mistaken for OCD, or can they work together?
Oh yeah, this is a great question, and this is actually a question that it's widely referenced in the literature because diagnostic physicians and psychologists and therapists, everybody struggles with this because part of autism is this intrinsic anxiety where they may repeat things and there are rituals often. So some of the behavioral and the social components of autism actually mirror or duplicate some of the OCD symptoms and criteria. So if you read those two sets, and there are book chapters on this and lots of publications, so you can read a lot about this and it's easy to find, but no one has a clear answer. So I think what we end up doing, what I end up doing in my practice is if someone meets criteria for autism spectrum disorder, I will give them that diagnosis. I will then separately take a look at the ritualistic behavior or the stereotypic behavior or the repeating or the verbalizations, for example. And I'll determine in my own mind, does this person also meet criteria for OCD, or are the obsessive thoughts and the compulsive behaviors, is it part of the intrinsic anxiety related to autism spectrum disorder, where you need things to be routine and you need things to be familiar and you need things to, and change is very difficult. So it's really it's a severity question for me. So if it's severe enough that it should be documented separately and medicated separately, for example, and luckily a lot of the medications that help with OCD will also help with autism. So it doesn't mean that we have to move to polypharmacy. It just means that we have to determine the severity of the obsessions and the compulsions and the repetitiveness, and then determine if it's a diagnosis in and of itself, the OCD, or if it's part of the autism, if it's intrinsic to the autism. That's how I look at it. But there's a lot of debate in this area, so it's sort of a fun topic.
That does appear to be the last question that we have in for the subject matter this afternoon.
Thank you so much to Megan for directing the questions at the end and for all the IT assistants. And thank you to everyone who joined the seminar. It's been an honor being with you today. And thank you for all that you do for our patients with ID.